Very important topic, diarrheal disorders in children. Diarrheal disorders are major contributors of under 5 mortality. Types acute, persistent, and chronic. Acute is when it's less than 7 days and the cause is infections. Persistence is when it is more than 14 days and it is due to prolonged infection. Chronic is when it is more than 14 days but staying up to months. Then it is non-infectious causes, especially malabsorption. Acute diarrhea. Most common cause is rotavirus. We also give vaccines for rotavirus. It's oral drops at 2 and 4 months, can be repeated at 6 months as well. Other viral causes as is Norvac, adeno, astro, and calicivirus. Most common bacteria is enterotoxigenic E. coli. Dysentery is diarrhea plus blood and stool. Most common cause is Shigella flexneri. What is the most common cause? Shigella flexneri. Dysentery is diarrhea plus blood and stool. Dehydration. Primary concern in diarrhea is dehydration. Look, feel, decide, and treat. Assessment of dehydration. So you assess it as no dehydration, some dehydration, and severe dehydration. What is the condition in no dehydration? Child is active, playful, and alert. Their eyes are normal. There are no tears. The tears are coming normally. Mouth and tongue is normal. Thirst is normal. Skin pinch test is fast, that is less than 1 second. Some dehydration. The child will be irritable with sunken eyes, no tears, dry tongue and mouth, excessively thirsty, and slow skin pinch test that is less than equal to 2 seconds. Severe dehydration. Child is lethargic. Child doesn't respond even when you arouse the child. Cannot be aroused. Very sunken eyes. Absent tears. Very dry mouth and tongue. Unable to drink water. Very slow skin pinch test. What is the skin pinch time in severe dehydration? It is more than 2 seconds. Skin pinch testing. Pinching the skin, let go, evaluate time taken for skin to go back to normal. Testing for skin turgor and elasticity. Skin turgor depends on interstitial fluid. In dehydration, decrease fluid and decrease turgor. So, skin pinch testing is pinching the skin, letting go, and evaluate the time taken for skin to go back to normal. Testing for skin turgor and elasticity. Skin turgor depends on interstitial fluid. In dehydration, the interstitial fluid is low and hence the turgor is low. Interstitial fluid provides elasticity. Skin management. In no dehydration, you use plan A, which is to use low osmolarity ORS. What is the composition? Glucose osmolarity is 75, sodium same 75, potassium 20, chloride 65, citrate 10. Total is 245 milliosmol per liter. Sodium and glucose is 1:1 ratio for maximum absorption via SGLT1. Alternatives for ORS at home, which is very important: salted rice water, salted yogurt, soup with salt, fresh fruit juice without sugar, tender coconut water. Avoid packed juices due to added sugar. Amount of ORS. Principle: replace ongoing losses. Age. Amount of ORS per loose stool. So how to replace ongoing losses? If it's less than 2 years, then you give 50 to 100 ml per 1 bm, 2 to 10 years, 100 to 200 mil, more than 10 years, ad lib. In some dehydration, plan B, ORS is used to correct dehydration steps. Rehydration 75 ml per kg ORS over 4 hours. Replacement of ongoing causes same as plan A. Daily fluid requirements maintenance, holiday, cigar formula. ORS is used to correct dehydration. Rehydration 75 ml per kg ORS over 4 hours. Replacement of ongoing losses same as plan A. Daily fluid requirements maintenance, holiday cigar formula. Weight. First 10 kg daily fluid requirements 100 ml per kg. 10 to 20 kg 1000 meals first 10 kg plus 50 meal for every kg after 10 kg. More than 20 kg 1500 meals first 20 kg plus 20 meal after every kg after 20 kg. That is the daily fluid requirement as per weight. In severe dehydration, plan C, you give IV fluids, ringer lactate plus 5% dextrose. In severe dehydration, you give IV fluids, ringer lactate plus 5% dextrose. Cannot give oral fluids due to unable to be drinking capacity and lethargy. Rehydration 100 ml per kg for replacement. How do you rehydrate? 100 ml per kg for replacement. 100 ml per kg for replacement. Less than 1 year. First hour 30 ml per kg. 5 hours 70 ml per kg. And this is for less than 1 year babies, and total time is 6 hours. So the first hour you will be giving 1 hour 30 ml per kg, and then for the second 5 hours 70 ml per kg, and total 6 hours. More than 1 year, for the first 30 minutes 30 ml per kg, and then another 2.5 hours 70 ml per kg, total 3 hours. That's the plan C. Zinc 14 days plays a role in GI reepithelialization, recovery of damage, decrease risk of persistent diarrhea. So if with a baby is less than 6 months, dose is 10 milligram per day. If the baby is more than 6 months, dose is 20 milligram per day. Less than 6 months, 10 milligram per day zinc. More than 6 months, 20 milligram per day zinc. Additional drugs. Dysentery. Third generation cephalosporin is added. In dysentery, third generation cephalosporin is added. Vomiting, antiemetics is added. Or it could be ondansetron, 0.50 milligram per kg per dose orally. What is the dose of ondansetron? 0.15 milligram per kg per dose orally. Probiotics prescribed based on cost benefit analysis. Probiotics is prescribed based on cost benefit analysis. Lactobacillus rhamnosus and Saccharomyces boulardii. Probiotics which has Lactobacillus rhamnosus and Saccharomyces boulardii. Cost increase and benefits is not that much. If the patient can afford it, only then prescribe probiotics. The bacillus is Lactobacillus rhamnosus and Saccharomyces boulardii. Convulsions with diarrhea. Etiology: electrolyte and metabolite imbalance, hyponatremia, hypernatremia, hypoglycemia, Why can there be convulsions with diarrhea in children? It could be due to electrolyte imbalance like hypo or hypernatremia or hypoglycemia. Second, infections can cause febrile seizures and meningitis, encephalitis, CNS infection. So there could be febrile seizures, an infection, and meningitis and encephalitis, CNS infection. Dehydration cause thrombosis in cerebral blood vessels. Dehydration can cause thrombosis in cerebral blood vessels. Cerebral venous thrombosis, sagittal sinus thrombosis. Cerebral venous thrombosis or sagittal sinus thrombosis. Cerebral venous thrombosis or sagittal sinus thrombosis. Persistent diarrhea, risk factor. Malnutrition. Coming to persistent diarrhea, what are the risk factors? Malnutrition, and it's due to decreased immunity. Malnutrition can decrease your immunity. Immunodeficiency, management, fluids. ORS versus IV fluids depending upon the degree of dehydration. Second, zinc. Third, vitamin A. Supports immune system, maintains mucosal integrity, antioxidant properties. Vitamin A supports immune system, maintains mucosal integrity and antioxidant properties. Fluids, ORS versus IV fluids depending upon degree of dehydration. And zinc. Weight and single dose of vitamin A. If weight is less than 8 kg, you give 1 lakh international unit. If weight is more than 8 kg, 2 lakh international unit. Restriction on lactose, persistent diarrhea, damage to villi, decreased lactase, lactose intolerance, unabsorbed lactose, goes to colonic bacteria, H2 formation, gaseous stool, and lactic acid in stool decrease pH, perianal excoriation, restriction on lactose in persistent diarrhea. And villi has enzymes like lactase, and enzymes are decreasing. So in persistent diarrhea, enzymes are decreasing, and then that's why you can have like gaseous stools and also perianal excoriation. Diet: you have to decrease lactose. Restriction of milk less than 50 ml per kg per day in persistent diarrhea. How much milk can be taken? Less than 50 per kg per day. If no response, then no lactose diet. Decrease sugars and starch. Plain glucose, egg cereals, egg whites, chicken. No response, no lactose, no starch. Only egg yolk, chicken, protein. Plain glucose is easily digestible, that's why. Due to villi damage, enzymes that digest complex carbohydrates are reduced, and digestion doesn't take place properly. So you have to restrict milk up to 50 milligram per kg per day, or just stop lactose and sugar altogether. Celiac disease: gluten hypersensitivity causing chronic diarrhea, food intolerance, celiac disease. Gluten hypersensitivity causing chronic diarrhea, gluten containing foods, mnemonic, bro. So if there is a hypersensitivity, that is allergy, food intolerance to gluten, then it can cause chronic diarrhea, that is your celiac disease. What foods have gluten? The mnemonic is bro. B for barley, R for rye, O for oats, W for wheat. Oats relatively well tolerated, wheat is most commonly implicated. Bro. B for barley, R for rye, O for oats, W for wheat. Genetic predisposition: HLA DQ2 and DQ8. HLA DQ2 and DQ8. I know a child who has this and they only eat rice all the time. Pathology: T cell mediated autoimmune disorder. Pathology is T cell mediated autoimmune disorder. Genetic predisposition plus gluten consumption, gliadin, intestinal absorption, T cell stimulation, B cell stimulation, autoantibodies, and intestinal injury. What happens is that when someone is already genetically prone to it and then they consume gluten, then it forms gliadin, which is absorbed. It activates T cell, it activates B cell, it makes autoantibodies, and it causes intestinal injury. Association: it is associated with Down syndrome, Turner syndrome, Hashimoto's thyroiditis, selective immunoglobulin A deficiency, type 1 diabetes mellitus. So Down syndrome, Turner syndrome, Hashimoto's thyroiditis, selective IgA deficiency, and type 1 diabetes mellitus. Clinical features: onset more than equal to 6 months after stoppage of exclusive breastfeeding. It can start after 6 months when exclusive breastfeeding is stopped. Due to malabsorption, there will be a failure to thrive and a chronic diarrhea. Anemia due to iron duodenal absorption and folic acid terminal ileum deficiency. Why is there anemia? Due to iron and folic acid not being absorbed. Iron is absorbed in duodenum while folic acid is absorbed in terminal ileum. Dimorphic anemia can present as iron refractory anemia. Dimorphic anemia, and it can present as iron refractory anemia, failure to thrive. Diagnosis: serology, screening, qualitative, anti-TTG, tissue transglutaminase antibody, best anti-endomysial antibody. Serology screening, so qualitative, Anti-TTG, tissue transglutaminase antibody. Anti-TTG, tissue transglutaminase antibody. Best is anti-endometrial antibody. Note: quantitative serology test titers are seldom preferred. Quantitative serology test titers are seldom preferred. Small intestinal duodenal biopsy, investigation of choice in India. What is the investigation of choice? Small intestinal duodenal biopsy, investigation of choice. Villus atrophy, flattening, increase length of crypt, increase intraepithelial lymphocytes more than 30 per 100 enterocytes. Increase length of crypt and increase intraepithelial lymphocytes more than 30 per enterocytes. Small intestinal biopsy, duodenal, which is the investigation of choice in India. Villus atrophy, flattening, increase length of crypt and increase intraepithelial lymphocyte more than 30 per 100 enterocytes. Treatment: gluten-free diet lifelong. Avoid wheat and substitute with rice and maize. Avoid wheat and substitute with rice and maize.